present at Nephrology Grand Rounds today. Professor Sunil Badve, who's very well known to everyone, to most of us, but to the newcomers to the division, he is a professor. He's a conjoint professor of medicine at the University of New South Wales in Sydney. He's also the program lead for Cardiometabolic Trials in the Renal and Metabolic Division at the George Institute for Global Health in Australia. He's obtained his nephrology training from Mumbai and Ottawa, and then he's got a PhD from the University of Queensland in 2016. And he is, he's authored numerous papers. He has got over $12 million in grants as the principal investigator. And today he's going to talk about the anti-thrombotic treatment in advanced stages of kidney disease. Thank you, Sunil.
Thank you, Swapnil, for that introduction, and good morning, everyone. I'm excited to be here in Ottawa virtually. I was trained there for 3 years between 2005 and 2008, and certainly I have very fond memories of Ottawa. So these are my disclosures. I should point out that the study medications for TRACK trial are provided by Bayer, and I have also done some advisory board as well as I have taken some lecture fees from them, but all of these fees are paid to the George Institute. So these are the objectives of my presentation today. First, I will discuss the burden of cardiovascular disease and prevalence of major bleeding in patients who have advanced stages of chronic kidney disease. I will also review the current evidence on antithrombotic treatment for prevention of cardiovascular events in patients with advanced chronic kidney disease, and then I will describe the TRACK trial. So we are aware that compared with people with normal kidney function, those who have chronic kidney disease are at a greater risk of cardiovascular events. And these risks increase progressively as the kidney function decreases. This is a very famous slide that you probably have seen previously. Now, this is a Canadian data. This is a cohort study from Alberta. And the study showed that the risk of myocardial infarction increases with decreasing kidney function. And within each GFR category, the risk of myocardial infarction increased further with the worsening of proteinuria. Now, what happens to people with chronic kidney disease who experience myocardial infarction? Now, this is a population-based study from the Netherlands, and it shows that patients who have chronic kidney disease, and if they have myocardial infarction, their mortality rate is extremely high, and the mortality rate worsens with the worsening of GFR. On the right-hand side, you can see that this is the mortality, the risk of mortality within 30 days of myocardial infarction, and people who have advanced stages of kidney disease, such as stage 4 or 5, their risk of death is nearly 8.5 times greater than those with normal kidney function. And among those who survive the first 30 days after myocardial infarction, their subsequent mortality risk is approximately 3.5 times greater than those who have normal kidney function. It's not just myocardial infarction, the stroke risk also increases with the worsening of GFR. This is an individual participant meta-analysis using data from the Chronic Kidney Disease Prognosis Consortium. And the hazard ratio for stroke are described on the vertical axis, and eGFR is described on the horizontal axis, with higher GFR on the right side and lower GFR on the left side. And you can see that by the time patient reaches CKD stage 5, their hazard ratio is almost 2 compared to those who have normal kidney function. And it is not just the increased risk of stroke. So if you compare the stroke outcomes in chronic kidney disease patients with those who don't have chronic kidney disease, so patients with CKD suffer more severe stroke. They require much longer hospitalization, and they also have greater risk of neurological deterioration during their hospitalization, greater risk of in-hospital mortality, and if they survive, they have poor functional recovery at discharge. And these outcomes worsen further as kidney function decreases, and these outcomes are worse among patients who are on dialysis. This table shows the risk of death after ischemic stroke in older patients with CKD stage 4 and 5 compared to those patients who have CKD stage 4 and 5, but those who don't have stroke. And you can see that the first 30-day mortality rate in CKD stage 4 and 5 is nearly 4 to 5 times greater than those who don't experience stroke. And not only that, this mortality risk is not only within first 30 days, but even beyond that, even the long-term mortality rate remains persistently elevated in these patients. Coming to peripheral artery disease, PAD is also highly prevalent in patients with chronic kidney disease. Its prevalence varies between 25 to 35% in patients who are on dialysis, and among non-dialysis CKD patients, it varies between 10 to 15%. We have seen a similar graph for stroke risk. Now, this is from the same analysis, individual patient-level meta-analysis from the CKD consortium group. And on the left-hand side, this is the outcome is incident peripheral artery disease event, and on the right-hand side is leg amputation. And you can see that as patients' GFR decreases to around 30 or lower, the hazard ratio for incident peripheral artery disease event is almost 2, whereas the risk of leg amputation is more than twice compared to those who have normal kidney function. There is also significant association of chronic kidney disease with in-hospital mortality, long-term mortality, amputation rates, duration of hospitalization in patients with chronic kidney disease and peripheral artery disease. And the outcomes such as death or amputation, these outcomes are even worse in patients who have stage 4 or 5 chronic kidney disease compared to those who don't have chronic kidney disease or those who have early stages of chronic kidney disease. Compared to those with preserved kidney function, patients with advanced chronic kidney disease or those with kidney failure on dialysis are at increased risk of mortality and cardiovascular events after a revascularization procedure. And these events like cardiac arrest and myocardial infarction, they are greater in patients with CKD and those who have advanced stages, as well as those who are on dialysis. Coming to dialysis patients, the prevalence of PAD is as high as coronary artery disease. And if you look at 1-year mortality rate after a lower extremity amputation, it is extremely high. Nearly 45% of patients will die within a year of amputation if they are on dialysis. The rates of cardiovascular hospitalizations are also high in patients with chronic kidney disease compared to those who don't have chronic kidney disease. And even among those who have chronic kidney disease, the cardiovascular hospitalization rates are 83% higher in patients with CKD stage 4 and 5 than CKD stage 3. And what happens to these patients after their admission for hospitalization? Not surprisingly, the mortality rate is also high in these patients, regardless of which cardiovascular condition or event they have, whether they have coronary artery disease, stroke, or peripheral artery disease. After an admission for cardiovascular cause, their 2-year survival probability is very low. It is about 53% if they have coronary artery disease, 44% if they have stroke, and 47% if they have peripheral artery disease. So indeed, patients with chronic kidney disease are at a greater risk of not only all-cause mortality, but also cardiovascular mortality. And these risks increase exponentially with the worsening of eGFR. Now, what do these patients die of? So this is also Canadian data, which shows that a cardiac cause accounts for nearly 50% of all deaths in patients with advanced stages of chronic kidney disease, as well as kidney failure. Data from Australia and United States shows that among dialysis patients, a cardiovascular cause accounts for nearly 43 to 45%, including all cardiovascular causes. Now, individuals who are on dialysis have a 10 to 100-fold greater risk of death than the age and sex match general population. The 5-year survival rate of patients with dialysis-dependent kidney failure is worse than many commonly diagnosed cancers, including breast cancer and colorectal cancers. I'm sure you are familiar with this population study from Ontario, which was published a few years ago. And this study also showed that survival in dialysis patients was lower than several types of common cancers in both men and women. The mortality rate for an Australian dialysis patient is, on an average, is 10 per 100 person years. But you can see that this rate increases substantially in older patients who are on dialysis, as well as those who have diabetes and coronary artery disease. This is slightly older data. The first bar on the left-hand side shows death rate for all Australian dialysis patients. The second bar shows that if a dialysis patient is younger than 65 years, and that person does not have either coronary artery disease or peripheral artery disease, their mortality rate is quite low, just at 5 per 100 person years. But if this individual has either coronary artery disease or peripheral artery disease, then the mortality rate increases by almost threefold. This bar shows a dialysis patient who is older than 65 years, but does not have a coronary artery disease or peripheral artery disease. And if this individual develops either of these two conditions, then the mortality rate is even greater, almost 25 per 100 person years. The coagulation system in advanced CKD is profoundly impaired, such that these patients are not only at an increased risk of thrombosis, but also spontaneous bleeding. Now, this is a beautiful study published by Dr. Sood, and you can see that the risk of major bleeding increases as GFR worsens. And within each GFR category, the risk of major bleeding increases progressively. And you can see that this is a major bleeding rate, and it is described per 1,000 person years. Now, how does this bleeding risk compare to patients on dialysis? So this is the bleeding risk described in per 100 person years, and this is this data is from the Netherlands. The left bar is for patients on hemodialysis, and the right bar is for patients who are on peritoneal dialysis. And the bleeding risk in these patients is around 6.7 to 5.7 per 100 person years. So extremely high bleeding risk. Now let's review the current evidence on antithrombotic treatment. for prevention of cardiovascular events in patients with advanced stages of chronic kidney disease. So first of all, what I was struck by this particular article is that most cardiovascular outcome trials will exclude patients who have chronic kidney disease. And this particular analysis from 2016 showed that nearly 60% of all antiplatelet trials excluded patients with chronic kidney disease. And except for a few handful of vascular access trials, no trials have been conducted specifically in patients with advanced chronic kidney disease or those who are on dialysis. And I should also point out that the vascular access trials have been quite short-term, and they were not designed to assess cardiovascular outcomes. Now, if you look at anticoagulant trials, 90% of cardiovascular outcome trials have excluded patients with chronic kidney disease. And except for a handful of trials involving dialysis patients with atrial fibrillation, no trials have specifically been conducted in CKD patients, advanced stages of CKD patients, and kidney failure patients to improve cardiovascular outcomes. There have been a few trials evaluating vascular access, but these trials have also been of very short duration and not designed to assess cardiovascular outcomes. Now, this particular meta-analysis was published back in 2002. So obviously these data are quite old, but you can see that the use of antiplatelet therapy, it could be any antiplatelet therapy, including aspirin, ticlopidine, which we don't use nowadays. Any antiplatelet therapy reduce the risk of a vascular event by approximately 41%. However, this particular meta-analysis was limited by inclusion of only 2,700 patients, hemodialysis patients, and the median follow-up was only 3 months. So clearly, we don't have long-term data. This meta-analysis was published by a colleague and friend of mine, Swaitonia Palmer, about 10 years ago. And she showed that among patients who have early stages of chronic kidney disease, and the reason why I'm saying early stage is because except for one trial, data were excluded from except for one trial, all trials excluded patients with advanced stages of kidney disease as well as those who are on dialysis. There was only one dialysis trial, but that was a vascular access trial. And you can see that in CKD patients who undergo who present with acute coronary syndrome or those who undergo angioplasty, the effects on cardiovascular outcomes such as myocardial infarction, cardiovascular death, or all-cause death, all these effects were quite uncertain. However, antiplatelet therapy did increase the risk of major bleeding. Now, if you look at patients who have stable coronary artery disease, antiplatelet therapy was beneficial. It did reduce the risk of myocardial infarction and increase the risk of only minor bleeding. So clearly in early stage CKD, antiplatelet therapy is beneficial, but we don't have data in patients with advanced chronic kidney disease and those who are on dialysis. Now, this is a work done by my master's student, Dr. Lapchain. He has finished advanced training. And these data are not published yet, but we have presented these data at the American Society of Nephrology meeting a few years ago. And this comparison is for dual antiplatelet therapy versus aspirin monotherapy or no study medication. And it looks like, at least in patients with early stage CKD, dual antiplatelet therapy seems to be beneficial in terms of reducing cardiovascular events, but at a cost of increased bleeding. we could not really assess the net benefit, whether the benefit of reduction in cardiovascular events outweighed the risk of bleeding. And this is the same data, but we did a variety of different comparisons as well. Now, recently, we have more data from anticoagulation trials in dialysis patients. So on the left-hand side, I have kept the same data as my previous slide. So these are the bleeding rates in hemodialysis and peritoneal dialysis patients. The second group is VOYAGER study, in which about 130 hemodialysis patients with atrial fibrillation were randomized to rivaroxaban 10 milligrams daily, which is probably a therapeutic dose, versus dose-adjusted warfarin. And the bleeding rates were 9 and 22.7 per 100 years. So clearly, if you use therapeutic dose of anticoagulation, the risk of major bleeding increases further. Now, this is the third group is Excidia AFNet 8 trial, which was published late last year. And these events are in percentage; they are not they are not incident rates. But you can see that about 10.4% patients in the apixaban developed major bleeding, and 12.2% in patients who received a vitamin K antagonist. If you look at the renal AF trial, the bleeding rates were even greater, 31.5 in apixaban group and 25.5 in the warfarin group. So clearly, if you use therapeutic dose of anticoagulation, the risk of major bleeding is extremely high, and that bleeding risk may be greater than the benefit that your patient is likely to derive from it. But we don't have further evidence on that yet. So coming to the COMPASS trial, now the reason why I'm showing you the COMPASS data is because the TRACK trial is based on COMPASS trial. So I will spend a bit of time in describing COMPASS trial. So in this trial, more than 27,000 patients with coronary artery disease or peripheral artery disease and at least one additional cardiovascular risk were randomized to one of the three groups. The first group received very low dose rivaroxaban, that is 2.5 milligrams twice daily, in combination with aspirin 100 milligrams once daily. The second group received low dose rivaroxaban, that is 5 milligrams twice daily. And the third group received aspirin 100 milligrams once daily alone. Now, so these patients were needed to have either coronary artery disease or peripheral artery disease. And one of the many enriching cardiovascular risk factors was renal dysfunction with eGFR less than 60 ml per minute. However, those with eGFR less than 15 ml per minute were excluded from the COMPASS trial. So out of 27,000 patients, nearly or more than 6,000 patients had chronic kidney disease at baseline. So about 22% of the entire study population had chronic kidney disease. But if you look at the actual number of patients with CKD stage 5, CKD stage 4, they were quite low in comparison to the CKD stage 3. The primary outcome of this trial was major adverse cardiovascular events, which was a composite of cardiovascular death, myocardial infarction, and stroke. Now, the trial was stopped early when only 50% of planned events had occurred due to overwhelming benefit with the rivaroxaban aspirin combination. So compared to aspirin alone group, the risk of major adverse cardiovascular outcome with the rivaroxaban and aspirin combination was decreased by 24%. So it's pretty large and significant benefit. The combination of low-dose rivaroxaban and aspirin also reduced the risk of cardiovascular death, all-cause death, ischemic stroke, and venous thromboembolism. And although the risk of the primary outcome in the rivaroxaban alone group was lower than the aspirin alone group, it did not meet the statistical criteria pre-specified for the interim analysis. Now, this trial also enrolled about 6,500 patients with peripheral artery disease. And in these patients, it reduced the risk of acute limb ischemia, major adverse limb events, including major amputations and vascular amputations. So the benefit of using rivaroxaban is well beyond just cardiac benefits. As expected, the risk of major bleeding was also greater in the rivaroxaban aspirin group than aspirin alone group. However, there was no significant difference in intracranial or fatal bleeding between these two groups. And if you look at the lower part of the slide, you can see that this outcome is called as net clinical benefit outcome, which is a composite of primary efficacy outcome and fatal bleeding and bleeding into critical area or organ. And the net benefit clinical outcome was also in favor of rivaroxaban aspirin combination. Now, they also published CKD subgroup data, and this subgroup analysis, according to chronic kidney disease at baseline, showed that there was no significant interaction of efficacy by bleeding outcome. The relative risk reduction in major adverse cardiovascular events in chronic kidney disease was similar to those without chronic kidney disease. And you can see that the hazard ratios were nearly identical with the interaction p-value not significant. And the same thing was seen for cardiovascular death, stroke, as well as ischemic stroke. Now, what about bleeding outcomes? So similar to that of the efficacy outcome, the hazard ratios for major bleeding did not show statistical heterogeneity. And importantly, there was no increased risk of fatal or intracranial bleeding. And also, if you look at the net clinical benefit outcome, which was again a composite of the efficacy and bleeding outcomes, it was also in favor of the rivaroxaban aspirin combination in CKD subgroup as well. And the interaction p-value was not statistically significant. So what does this all mean to patients with chronic kidney disease? So if you look at the absolute risk increase in major bleeding in the CKD subgroup, it was 1.3%, and in patients who don't have CKD, it was 1.2%. So pretty similar. But if you look at the absolute risk reduction in MACE, it was 2% in the CKD subgroup and 1% in the non-CKD subgroup, suggesting that the bleeding risk was counterbalanced by a greater absolute reduction in cardiovascular events in the CKD subgroup, thereby rendering a positive net benefit. And that is clearly because the risk of major adverse cardiovascular events increase exponentially at lower levels of GFR. Now, similar to the COMPASS trial, there was another trial published. This trial is called as VOYAGER PAD. And in this trial, more than 6,500 patients with peripheral artery disease who have undergone a revascularization procedure were enrolled. And these patients were randomized to The same intervention, rivaroxaban 2.5 milligrams twice daily plus aspirin or aspirin alone. And the primary outcome was a composite of acute limb ischemia, major amputation for vascular causes, myocardial infarction, ischemic stroke, or death from a cardiovascular cause. And this particular outcome was also in favor of low-dose rivaroxaban aspirin combination. Now, we do have CKD subgroup data from this trial as well. And this analysis showed that the benefits of rivaroxaban were preserved among patients with chronic kidney disease. This was mainly driven by a reduction in major limb events with no observed heterogeneity of bleeding by GFR. Now, you might ask that the dose of rivaroxaban in the COMPASS trial is quite low. In fact, it is 75% lower than that is required for full anticoagulation. And the observed beneficial effect of low-dose rivaroxaban in the COMPASS trial cannot be explained by its anticoagulant effect alone. So what could be the other mechanisms by which rivaroxaban is beneficial? So preclinical studies showed that rivaroxaban inhibits the signaling of protease-activated receptor 2 by inhibiting factor 10A. Rivaroxaban also inhibits the signaling of protease-activated receptors 1, 3, and 4 by inhibiting thrombin. And these protease-activated receptors are critical for platelet activation and development of inflammation. These receptors are also involved in production of pro-inflammatory cytokines and endothelial adhesion molecules involved in atherothrombosis. So there is an alternate mechanism that has been postulated for this particular molecule. So I will now describe the TRACK trial. So TRACK trial, it is a large, simple trial. This trial has no designated trial-specific laboratory, radiological, or cardiologic investigations. We don't need to collect any data for any investigation during the follow-up. The study visits are flexible. Very minimal data collection are required, and there are no strict timelines for SAE reporting except SUSARs. So we have basically designed this trial with large, simple trial design concept, and that is somewhere between conventional trials and pragmatic trials. The hypothesis of the TRACK trial is that compared to placebo, low-dose rivaroxaban, that is the dose of 2.5 milligrams twice daily, reduces the risk of major adverse cardiovascular events in patients with CKD stages 4 or 5 or dialysis-dependent kidney failure and elevated cardiovascular risk with an acceptable bleeding risk. Now, why we are using rivaroxaban or low-dose rivaroxaban in the TRACK trial? So in addition to the promising data from COMPASS trial and the VOYAGER PAD trial, pharmacokinetic and pharmacodynamic studies show that rivaroxaban has predictable properties. The kidneys eliminate only 1/3 of the parent drug, and the remaining 2/3 is metabolized into an inactive form in the liver. So the influence of kidney function on pharmacokinetic properties in patients with creatinine clearance less than 30 ml per minute is considered to be only moderate. And pharmacokinetic studies also show that the terminal half-life of rivaroxaban in dialysis patients and CKD stage 4 patients is similar to that seen in healthy subjects. And importantly, the total daily dose of rivaroxaban in TRACK trial is only half to 1/3 of that required for full anticoagulation in this particular patient population. So the inclusion criteria are, we are enrolling adult patients defined as age greater than 18 years. The CKD criteria is patients need to have kidney failure on hemodialysis or peritoneal dialysis. And if they are not on dialysis, they need to have CKD stage 4 or 5 defined as eGFR 29 or lower, not receiving renal replacement therapy. And there is one more criterion, that is for the elevated cardiovascular or thrombotic risk, which is defined by at least one of the following: coronary artery disease, peripheral artery disease, ischemic stroke, diabetes, or age over 65 years. The exclusion criteria for this trial have been designed specifically with patient safety in mind. So patients who have mechanical or prosthetic heart valve are excluded. Patients who have an indication or contraindication to anticoagulant therapy are also excluded. High bleeding risk, including any coagulopathy, a lesion or condition that is considered to be at risk of major bleeding, are also excluded, and these conditions are listed at the bottom of the slide. And I should specify that AV graft or AV fistula for dialysis is not an exclusion criteria. Patients who have experienced major bleeding event in the 30 days prior to study enrollment, or those who have any active and clinically significant bleeding are also excluded. Now, if your patient is currently being treated with any of the following antiplatelet medications, such as clopidogrel, ticagrelor, or dipyridamole, these medications need to be stopped before study enrollment. And if the treating physician or patient do not wish to stop these medications, that's an exclusion criterion. The other criteria are current treatment with strong inhibitors of combined CYP3A4 and P-glycoprotein, or strong inducers of CYP3A4. Now, the list of this medication is quite small, and the chances of patients being excluded on this particular criteria are quite low. Patients with any stroke in 1 month will be excluded. Any previous history of hemorrhagic or lacunar stroke. Now, you don't need to have an MRI to document lacunar stroke. Patients with severe heart failure with known ejection fraction less than 30% or NYHA class 3 or 4 symptoms are excluded. And similar to the previous criterion, you do not need to conduct an echocardiogram to document ejection fraction. This is only if you are aware or if the patient is known to have ejection fraction less than 30%. The other exclusion criteria are uncontrolled hypertension, anemia, or thrombocytopenia. But these factors could be addressed adequately. For example, treating hypertension adequately with other antihypertensive medications or reducing patients' dry weight. If patients have anemia, raising hemoglobin levels with ESAs. The other exclusion criteria are significant liver disease, kidney transplant recipients with a functioning allograft, or those who are scheduled for living donor transplant surgery are excluded. Pregnant women or those who intend to become pregnant or breastfeeding women are also excluded. And inability to understand or comply with the requirements of the study is the last exclusion criterion. Now, the study has different phases. So the first phase of the study is screening and run-in visit, which can be done simultaneously. At this visit, you will get the informed consent signed, confirm eligibility, and we will need only a few data points at this study visit. some basic information on patient demographics, medical history, and concomitant medications will be recorded. We don't need any prospective laboratory investigations, but we do need a few investigations that have been done historically. So we need full blood count and AST because these are a part of the eligibility criteria, and eGFR and urinary albumin creatinine ratio if patient has CKD stage 4 or 5, and HbA1c if patient has diabetes. If you do not have urinary albumin creatinine ratio, urinary protein creatinine ratio is acceptable. And any recent reports that have been done in the preceding 6 months are acceptable. And we will also be collecting information on total cholesterol and triglyceride levels, and any reports within the previous 12 months is acceptable. At this visit, we will also record patients' weight and height, heart rate, blood pressure, and EQ5D5L questionnaire will be administered. Now, if your patient is on any prohibited medications, such as P2Y12 inhibitors or phosphodiesterase inhibitors or non-study anticoagulants, this is the time to stop those medications. And at this study visit, patients will be dispensed placebo tablets. And then the run-in phase commences, which ranges between 14 to 30 days, but average is likely to be about 21 days. And all participants will be asked to take a placebo tablet twice daily during this run-in phase. And the run-in phase also doubles up as a washout phase for prohibited study medications. Now, patients who complete a run-in period with at least 80% adherence to taking placebo tablet twice daily, and those who wish to continue in the trial will undergo randomization. And patients will be randomized in 1:1 allocation to either rivaroxaban 2.5 milligrams twice daily or matched placebo. And the randomization visit will be completed by dispensing the randomized study medication. Now, what about aspirin use? So unlike COMPASS and VOYAGER PAD trials, the use of aspirin trial in the TRACK trial is not mandatory. So participants who are already on aspirin at the time of randomization will be allowed to continue it in both trial arms. And in fact, the randomization is stratified by the baseline use of aspirin. For those who are not on aspirin, treating physicians will be allowed to prescribe this medication during the follow-up if they feel it is clinically indicated. The study visits are also kept quite simple. After randomization, there will be one telephonic visit at 1 month, followed by another telephonic assessment at 3 months, and then telephonic visits will be conducted every 6 monthly. The first clinic visit will occur at 6 months and then 6 monthly until the final study visit when the study termination is announced. 4 weeks after that, there will be one more telephonic study visit, and that will be the final study visit. Now, all participants will remain in the trial even if they permanently discontinue study medication, if they commence dialysis or change the dialysis modality, or if they undergo kidney transplant surgery. But those who undergo kidney transplant surgery, study medication will be stopped. If a participant does not wish to attend study visits, data can be collected remotely via either phone contact or just reviewing medical records or follow up with family members or other treating physicians, including general practitioners. In fact, all study visits can be conducted remotely, including randomization and consent process. Now, we have also streamlined reporting of adverse events and serious adverse events in this trial. So as a general rule, we are not collecting data on adverse events, non-serious adverse events, unless it leads to permanent discontinuation of the study medication. And for serious adverse events, again, data reporting is very streamlined. So SAEs that are study outcomes only needs to be collected on outcome CRA, and it does not need to be reported within 24 hours. In fact, it could be reported within 7 days of patient discharge. Now, we know that patients with CKD and kidney failure, they get admitted to hospital for a variety of reasons. And if hospitalization, the cause of hospitalization is consistent with the natural history of the underlying kidney disease, then that SAE also does not need to be reported within 24 hours, but within 7 days of discharge from the hospital. Now, only SUSARs, that is defined as suspected, unexpected serious adverse reactions, are to be reported within 24 hours. Now, I should point out here that rivaroxaban has been studied extensively in programs involving more than 100,000 patients. And apart from major bleeding, there has not been any significant concern about this particular study medication. And therefore, we expect either no or very, very few numbers of actual SUSARs to be reported in the TRACK trial. And of course, if you're particularly concerned about any event, you're more than welcome to report that event within 24 hours. The primary efficacy outcome of the TRACK trial, it's a composite outcome, major adverse cardiovascular event, and it is defined as cardiovascular death, myocardial infarction, stroke, and peripheral artery disease events. Now, we have a variety of secondary and tertiary outcomes, and these include the individual components of the primary efficacy outcome, all-cause death, net clinical benefit outcome, which is a composite of efficacy and bleeding outcomes, venous thromboembolism, and in patients who have vascular access already established, we will be collecting information on thrombosis of dialysis vascular access. Now, coming to very important outcomes, that are safety outcomes. So our first safety outcome is major bleeding, and it is defined as either fatal bleeding or symptomatic bleeding in a critical area or organ, or bleeding into surgical site requiring reoperation, or bleeding leading to hospitalization. And the second safety outcome is gastrointestinal bleeding. Especially, we are looking at upper gastrointestinal bleeding. Now, as far as the sample size is concerned, assuming a primary event rate of 10 per 100 person years in the control group, we need 1,886 participants, and that will provide us 90% power to detect a 25% risk reduction. And this is the same hazard ratio that was observed in the COMPASS trial. This is an event-driven trial, and the study will continue until a total of 515 participants experience a primary endpoint event. Now, we have developed extensive guidance on risk mitigation for a variety of clinical scenarios, and all this information is available in the trial protocol. And this information is also available on the trial website, that is tracktrial.org. We are also giving patients the safety cards that they can carry in their wallet that will have a link to the trial website as well, with clear instructions on and there are clear instructions that anyone who can log into a website can view this information without the need of any username or password. So that's my last slide. So thank you for your attention, and I'm happy to take any calls, any questions.
Fantastic. Thank you, Sunil, for that great overview and for planning and taking this trial off the ground in a very much needed population. If people have questions, please raise your hand and unmute yourself, but I'll start the ball rolling. On the trial itself, if I can ask a little bit more about the exclusion, you very precisely said it's excluding if there is an indication for anticoagulation. The practice locally for atrial fibrillation varies. So I assume atrial fibrillation is not an exclusion if we decide they don't need to be an anticoagulation. Am I reading this right?
You're correct, Swapnil. So I entirely agree with you that not all patients with atrial fibrillation on hemodialysis are anticoagulated. So if you so in that case, you can enroll that patient in this trial. However, you need to keep it in mind that the dose of anticoagulation or the dose of rivaroxaban in this trial is not intended for therapeutic anticoagulation. So if your intention is stroke prevention in the setting of atrial fibrillation, then this is not the trial for that particular patient. Here we are looking at overall cardiovascular benefits. That includes, of course, stroke, but that also includes coronary artery disease events, peripheral artery disease events, and cardiovascular death.
Yeah, sounds good. And the what was, maybe I missed this, what was the reason to exclude heart failure and NYHA 3 and 4? Because I'm wondering if that will exclude a bunch of our patients.
So so this particular trial is based on the COMPASS trial, and it was an exclusion criterion in the COMPASS trial. Having said that, Commander HF trial was conducted using low-dose rivaroxaban in patients who do have heart failure, but that trial did not show any benefit with low-dose rivaroxaban. Now, there could be a variety of reasons for that because the outcomes were slightly different than the COMPASS trial, but we decided to follow the COMPASS trial, which was published first. And as soon as the COMPASS trial was published, we started working on this trial.
And then possibly the efficacy in that population may not be there or something along those lines.
Well, we can't really extrapolate that to the study, to track study population. So I can't answer your question that confidently.
Yeah, no, thank you. That's fair enough. And while people are, Deb has a question. I'll let her ask first.
I know you mentioned on the one slide about mitigation strategies for things like surgery, but would you mind just sharing what that mitigation strategy is, given this patient population? Many of them, or presumably, will be on the deceased donor transplant list, and we often don't have a whole lot of time when we're calling them in?
Yeah, so that's a good question, Deb, and we are expecting that patients who are on the waiting list on the deceased donor transplant not to be enrolled in this particular trial, because one thing is that these patients, you cannot delay transplant surgery, whereas according to these risk mitigation strategies, you need to delay the trial by approximately 24 to 36 hours, depending on the bleeding risk. And to your other question, so we are really looking for patients who have established cardiovascular disease, those who are old, to participate in the trial. The current data shows that almost 87% trial participants or 83% trial participants have diabetes. So I expect many of these patients are unlikely to be eligible for transplant?
I'm not sure that that's necessarily true here. But interestingly, the way Trillium Gift of Life works here, people are often waiting, certainly more than 24 hours from the time that we actually call them in. But I get your point about the challenges with the deceased donor list.
Yeah, in fact, in Australia, in certain centers and certainly in New South Wales, they will not put a patient on the waiting list even if the patient is on clopidogrel, because clopidogrel has much longer half-life and you need to wait for almost a week for any procedure. Compared to that, the terminal elimination half-life of rivaroxaban, even in dialysis patients, is only about 8 to 9 hours. So technically, you need to wait for half-life that is, you need to wait for time that is 2 to 3 times than the half-life. And this is not therapeutic anticoagulation. So the chances of bleeding compared to someone who is on therapeutic anticoagulation are still going to be quite low.
Yeah, if Deb doesn't have a follow-up, I ask a follow-up on that. So let's say I have a patient who's been enrolled in the trial. They are not on the deceased donor transplant list. But then they do get a workup, or maybe they're not even on dialysis, and then they go on dialysis next year and they get listed. Would should we then take them out or say, hey, we are discontinuing their trial participation? Is that, again, I suspect that's an uncommon, from your experience in Australia, that's uncommon, but it's something we might face here.
Yeah. So to answer that question, Swapnil, you are allowed to stop study medication at your discretion, but we still want we still want this participant to follow in the trial for intention to treat analysis.
Sounds good. So again, we are really excited to be part of this track trial. I hope it will be very successful and will enroll, the roughly 2,000 patients that are involved. If no one else has any question, I have one last follow-up question. Is that, not directly related to this, is that the results of the COMPASS trial are pretty convincing, and the other peripheral arterial disease trial you showed. From that data, everyone who's in the GFR 30 to 60, and we see a lot of those patients, should be with high cardiovascular risk, should be on rivaroxaban. I don't do that. I don't know if others do that. Is that your experience as well? Should we be doing that as well?
So there have been certainly some implementation issues with the results of COMPASS trial, and we do see that there is substantial lag between the trial publication and the uptake of that result. The utilization of rivaroxaban in that population in Australia is also much lower than what I expect, but I don't have any clear idea about why the implementation rates are still quite low. One possibility, Swapnil, is that in cardiovascular outcome trials, they have been very successful in improving at least short-term outcomes and short-term mortality. So their bar is now set quite high. And I wonder whether cardiologists don't get excited by cardiovascular trials anymore.
It's quite possible, but we don't have any interventions apart from, of course, Flozins now in this population. So I'm going to look at
but not in track populations, Swapnil.
Yes. Yeah, but in the 30 to 60, I think it's worth looking at expanding the use of at least or starting. I have personally never prescribed rivaroxaban in that population, but it's something worth considering. And again, I hope track is successful. Whatever be the results, it's the kind of data we do need in our patient population. Thank you again, and I hope you are able to make it for our reunion in late October, and good luck with the track trial.
Thank you, Swapnil, and I'll be excited to be there in person. Thanks, everyone. Have a good day.